Good afternoon, everyone. I'm Dr. Pratik Tambe, Chairperson for the AMOX Endocrinology Committee, and a very warm welcome to all of you, respected dignitaries and faculty, who have assembled today for this program, which is themed on high risk pregnancy. We have a host of stalwarts, eminent key personalities from all over the country who are here both as chairpersons and as speakers for this event. Next slide, please. But before we start, I would like to first welcome our chief guest for today, none other than Dr. Nandita Palchetkar, who's the president of AMOGS, the immediate past president of FOXY. Madam has also been a president of the Mumbai OBGYN Society, president of IAG in the past, and she has bestowed her blessings on all of us juniors. I think Amey and Rohan are testament to the fact that she's always supported, promoted, and encouraged all of us juniors in the Mumbai OBGYN Society throughout her tenure, whichever organization she may be heading. In fact, for the last 6 months during the pandemic period, we have gone ahead and executed so many programs, so many academic activities, thanks to her blessings and her support. Without further ado, I hand over the mic to Madam to bless us and give us some encouragement and her words of wisdom.
Hello. Thank you, Pratik, for those lovely warm words. I think it makes me feel very nice to see all you youngsters doing so well. I think especially, Pratik, Amey and Rohan have worked really hard for Foxy. And a special word about Amey as he steps into his next role. He's going for the vice presidency of AMOGS, and I would really like to bless him with all his future endeavors. And I'm sure, you have that ability. You've taken the best parts from all the people that you've worked with, and you will really become a very, very successful president, successful organizer, everything. I think it's an amazing quality which you have. And I'm so happy to see Archana and Parag, two of my very close friends, and who are also, I think Parag also has a lot of potential in him, and he's really done a fantastic job of the ICOG. I've seen him, and Archana has always worked with me, and I think the love is mutual, admiration, and it's fantastic. And my dear Vice President Pardesi Sahib, good evening, good afternoon. He's another dynamic person whom I was so happy to have as a vice president during my year, because there were so many programs that we set off, and all these people have participated. And welcome, Mala. I think it's always a pleasure to hear Mala. Last time when I heard her, the talk was very good, and there are a lot of take-home points which she gives, and I think this is a topic which is very close to her heart. She'll definitely do great justice to it. And I think, Pratik, high-risk pregnancy is very, very important, because as we say, because the SDGs are 2030, and COVID has actually set us back a little bit. But what we are doing to counter this is these kind of CMEs, where we spread knowledge to all our people so that they can treat their patients, give the women of this country the best healthcare with the most updated knowledge. And I'm really happy to see everybody doing that, disseminating knowledge. And I wish you all the best. And I think I'm really happy to see you working as a person and doing phenomenal work. Welcome, Parikshit. Good to see you there. Thank you. Thank you very much.
Thank you so much, ma'am, for those wonderful words. Amey, do you want to take a moment to respond to madam?
Thank you, madam, for those blessings. It's indeed an important responsibility that I've decided that I will take over. And I think that with blessings from you and the other seniors from AMOX, I assure you that I will take AMOX to greater heights. You have already raised the benchmark, and all your VPs, Dr. Pardesi, Dr. Kiran, I'm looking forward to working with them and make AMOX a unified, a powerful, and a vibrant force as it is now, to even greater heights. So thank you so much, madam, for all these opportunities that you have given me, both in FOXY as well as in AMOX.
Thank you so much, ma'am, for gracing the occasion and giving us your
Pratik,
blessings.
Pratik, 1 minute. I think I
Yes, ma'am.
saw Mandakini somewhere. Uh, I think she's gone right now, but she's another stalwart in genetics, and it's always a pleasure to hear her. So please tell her, please convey my regards to her. Thank you, Pratik.
Yes, ma'am. Thank you so much. Shriman, session, can we have the slides of introduction back up, please? I'd also like to place on record our gratitude to the Secretary of AMOGS, Dr. Arun Nayak, as I said, and as I usually say, that he's always been there to support and encourage us. Yesterday, he was there at an MOGS event which we had organized. We are missing him today. Hopefully, we will have him on the AMOGS platform also very soon. Next slide, please. We should also at this point acknowledge the chairperson of ICOG, Dr. Mandakini Meg, and the secretary of ICOG, Dr. Parag Biniwale, who is one of the chairpersons, for granting us the ICOG credit points for all our events so far, including today's program, which is accredited for one ICOG credit point. We have four fantastic chairpersons for today's event. The first is none other than Dr. Rajendra Singh Pardeshi. Sir is the current vice president of AMOGS. Last year, he was the vice president of Foxy. He's presented 27 papers in national conferences, six times Best Paper Awardee at AICOG conferences, and he's one person who we always look up to because he's come up from such humble roots and he's graced one of the highest offices of the land as far as professional organizations go. We're really happy to have Dr. Rajendra Singh Pardeshi here with us today. Next slide, please. Dr. Archana Verma, the Vice President elect of Foxy from the North Zone, is a dynamic personality and she's somebody who doesn't leave anybody untouched whenever she meets them. She's been the Public Awareness Committee Chair for the past 3 years, 2016 to 18, recipient of Limca India Book of Records, Best Presidential Committee Award, several other awards. We first crossed paths when she was the organizing secretary of North Zone Yuva Foxy in 2016, and she's come such a long way. We are really looking forward to next year when she takes over as the vice president of Foxy. She's done fantastic work last year when Dr. Nandita Palshetkar was the president of Foxy by organizing health camps for our CRPF personnel in the immediate aftermath of the Pulwama incident, and that helped a great way to building bridges with the defense personnel for OBGYNs in general and Foxy in particular. So we'll always be indebted to you for that. Thank you so much, ma'am, for gracing the occasion. Next slide, please. Dr. Amay Purandare, as is well known, is somebody who has passed through the ranks and come up in AMOGS over the past 3 decades. He's been in the past the honorary secretary of AMOGS, the zonal coordinator and state coordinator, which is the position he occupies currently. Very soon, we hope to see him as a vice president and hopefully in the future as a president of AMOGS as well. He's been the joint secretary of Foxy last year, chairperson of the Food, Drugs and Medico Surgical Equipment Committee of Foxy in the past. Currently, he is also the assistant administrator for the Foxy Manyata project on quality care in safe childbirth. Of course, he is also a well known member of the managing committee of the Mumbai OBGYN Society and a youth council mentor for the MOGS. Next slide, please. Dr. Parag Biniwale is currently the secretary of ICOG, and whenever we write to him for ICOG credit points, it is less than 1 hour since the sending of the email and receiving the reply. He's always on his toes, no matter whether it's day or night. Besides that position, he is also the president of the Menopause Society of Pune, national joint secretary of IMS in the past 2017-18, website editor of Foxy 2011 to 17, and a peer reviewer of the Journal of OBGYN of India. In the past, he's been chairperson for the Young Talent Promotion Committee of Foxy, and he's a very well known teacher for several different programs which he's conducted over the past 8 to 10 years and delivered several orations and guest lectures in over 120 Foxy societies. We are really happy to have Dr. Parag Biniwale with us. I would hand over the further proceedings to the chairpersons and request them to take us through. We have three wonderful speakers, Dr. Mala Aroda, Dr. Mandakini Pradhan, and Dr. Parikshit Tang present here today. And I hand over to to the chairpersons to take us further.
Yes. Hello.
Pardesi sir,
Yes,
Pardesi sir,
yes.
if you could speak more.
Yes, yes. Hello, good afternoon, everybody. Today, we would like to invite Dr. RPL Mala Arora. And I am forgetting name of Mala Arora, RPL. She is RPL woman. She has done tremendous work in RPL and really done work because it's a subject, as Dr. Nandita told, every woman we have to give them results, and RPL is a very interesting subject, and we have to deal with all, and we have to satisfy all our patients. Mala Arora, she is the chief editor of Recurrent Pregnancy Loss, Chief Editor of World Clinics in Obstetric and Gynec, DC Datta Award for Year Book of Gynae, Chief Editor for First Trimester of Pregnancy, then Hyperhomocystinemia, Associate Editor of International Journal of Infertility and Fetal Medicine, Peer Reviewer of British Journal of Gynae and Journal of Human Reproductive Sciences. Every time, so we love to hear from her. Just 2 days back only, I heard her topic on RPL. So over to Dr. Mala Arora. Over. Thank you so much.
Thank you. Thank you for your very kind words, Dr. Pardesi. And thank you, AMOGS. Thank you, Nandita, Pratik, Ameya, for inviting me to this platform. I know RPL has been talked about a lot, and I'm thankful you still want to invite me and hear to this subject. But today we are going to just focus on autoimmunity, which is a cause of poor pregnancy outcome. And as you know, we are all going through difficult times, and we need to pray for the world to deliver this world from this pandemic as soon as possible. I bring you greetings from the Indian College and Noble IVF Center. And the journey of RPL and autoimmunity was very little talked of when we first wrote the first book in 2003. Apart from APLA syndrome, the rest of the autoimmune problems were not investigated at that time. But by the time we are in the present year, we look at all these factors that cause RPL, and what is missing from this chart is autoimmunity. And it's missing not because it's not important, but because we're going to talk only about it today. For a long time, this large group of unexplained pregnancy loss has baffled everyone. And if we combine our refined genetic tests and autoimmune screening, it is postulated that only 10% will then remain unexplained. We would be able to explain most of the miscarriages. As you all know, immune tolerance to the fetus by the mother is pivotal for a healthy pregnancy outcome. And any autoimmune disorder in the body, whether it be in the pelvic region or not, will disturb that balance. So, not just recurrent pregnancy loss, autoimmunity will cause fetal growth restriction, hypertensive disorders of pregnancy, and a higher incidence of stillbirths. So, it is very important to understand this concept. I had noticed even in my clinical practice that any autoimmune disease, be it thyroiditis, SLE, vitiligo of the skin, alopecia areata, celiac disease, rheumatoid arthritis, or any other autoimmune disease for that matter, will result in a poor pregnancy outcome. So it's not just APLA and primary and secondary APLA and SLE, but the whole gamut of more than 80 autoimmune diseases. And as you probably are aware, autoimmune diseases are rising globally. They are 9 to 10 times commoner in women than in men, especially Hashimoto thyroiditis. The triggers for autoimmunity may be chemicals in our environment, viruses, bacteria, or what is coming to light now, perhaps diet. Diet is important as autoimmunity is very closely linked to a leaky gut syndrome. And in our diet, there are 5 highly antigenic foods, and all these are high protein foods. And these are eggs, meat, soya, peanuts, and dairy. And what is missing here is also gluten. So, gluten and dairy, as well as meat and eggs, form a staple part of our diet. And they have large protein molecules that, if absorbed undigested, can pose as antigens to our immune system and trigger autoimmunity. So, a vegan diet, which you have heard so much about, benefits most autoimmune disorders. And when you hear functional medicine specialists, and my daughter is doing a fellowship in functional medicine, the first thing they have to do when they see any person with autoimmunity is to fix their gut, because they have to fix the leaky gut to not absorb undigested protein molecules. And for that, you have to go on a FODMAP diet, which eliminates all dairy, gluten, and allows your gut mucosa to heal. Now, the interesting thing is that all these autoimmune diseases affect the female reproductive physiology by altering the natural killer cell population in the endometrium, by increasing the inflammatory cytokine production, TNF alpha, and producing a Th1 pro inflammatory response in the endometrium. Now, this has been studied and amply showed in experiments. But let us see what are the studies we have as evidence for autoimmunity and recurrent miscarriage. So this study is from 2015, and here 515 patients were screened for autoantibodies. And these patients were all RPL patients, and they did 5 antibody tests: ANA, double-strand DNA, thyroglobulin antibody, anti-mitochondrial antibody, and anti-smooth muscle antibody. And they found that the incidence of having at least one of these antibodies positive in the RPL group was 28%, versus in the control was half of that, 14%. We have all heard a lot about thyroid autoimmunity, and positive thyroid antibodies are seen in 31% more pregnant ladies who have a history of 2 previous miscarriages compared to pregnant controls who do not have a history of miscarriages. So there is a very definite link between thyroid autoimmunity and miscarriages. Now, what is the solution? Should we be treating women that have thyroid antibodies with thyroxine? And this is a question that has not well been answered so far. So there is no doubt that women who have high TSH levels need to be treated with thyroxine. But what if the woman is euthyroid and she has positive TPO antibodies? Would you treat her with levothyroxine? Would that improve the pregnancy outcome? Well, I quote to you this study that came from 2019, Negro et al. Did a randomized controlled trial and gave levothyroxine to half and placebo to half the women who were euthyroid and had thyroid antibodies. And they found no difference in the outcome in the 2 arms, both by way of miscarriages as well as preterm labor. And there is another large trial which is ongoing since 2015 called the T4 Life Study, whose results are still awaited to tell us whether thyroxine replacement is beneficial or not. Now, vitamin D, we have all heard how endemically every one of us is deficient in vitamin D, and I very religiously take my yearly shot of vitamin D. It has been associated with a lot of immune modulatory disorders. So this is a study on 133 women with RPL, of which 63 had low vitamin D. And the group that had low vitamin D had a higher prevalence of APLA syndrome, ANA antibodies, smooth muscle antibodies, single-strand DNA antibodies, TPO antibodies. And this study was published in 2014. Women who have celiac disease or antibodies, anti-gliadin antibodies, we tested women with unexplained miscarriages and failed IVF and found that they had a higher incidence of anti-gliadin antibodies as compared to controls. And here again, gluten-free diet helped them. There are further studies which have looked at IgG subclasses, and it showed that IgG deficiency could be occurring in some RPL women, and that may be responsible for poor pregnancy outcome. And this group that had low IgG levels did well after getting IVIG therapy. So, as we said, it is important that we keep autoimmunity in mind when we are looking at a woman with recurrent pregnancy loss. And there could be so many papers out there telling you that there could be microRNA mutations in patients with recurrent pregnancy loss. But the problem in clinical practice is which antibody do you test? Because there is a whole range of antibodies testing available and they are costly. So anti-nuclear antibodies seems to be your preferred choice, and that is why it is at the top of the list. Should be your initial screening test. And in reducing order, you could do double-strand DNA, smooth muscle antibody, mitochondrial antibody. Thyroglobulin should be higher up, not so low down, and SSA Rho antibodies. A crude test for inflammation is also your C-reactive protein and ESR. So if you have high levels of C-reactive protein, you're dealing with either infection or you're dealing with inflammation, which is autoimmune. So that can be another screening marker test. The ESHRE guidelines, which was the most latest guideline in 2018, said that anti-nuclear antibody testing could be considered for explanatory purposes. There is insufficient evidence to do natural killer cell population and to do TNF alpha levels or cytokine polymorphism because there is not enough evidence that these tests help. But let us focus on the anti-nuclear antibodies. Another very interesting concept I wanted to bring to all of you is that, when the placenta is undergoing apoptosis, as in a miscarriage or a stillbirth, it pushes huge amounts of fetal DNA into maternal circulation. And so there has been a pilot study which looked at cell-free DNA levels in patients with APL syndrome. And they looked at 4 pregnant patients with APLA positive and normal pregnant controls. And they said that the cell-free DNA levels were not elevated in the APLA syndrome population if they were treated. However, there is, Jolie Simpson has recently commented that NIPS can be offered early in women with recurrent miscarriages because they have more than 4% fetal fraction DNA earlier on if they are undergoing placental apoptosis. So this is the meta-analysis which has come out in 2020, July. And this meta-analysis has clearly proved that the miscarriage rate was 28% in women who were autoimmune positive and 14% in the control group, a highly significant p-value. Their cutoff was an ANA titer of more than 1 in 160 and a persistently positive ANA titer. The rest of the antibodies are left up to the clinician to test or not, but the take-home message I want to give you is that your women with unexplained miscarriages, please do an ANA titer and see if that is high, you're probably dealing with an autoimmune disorder. A very new paper that I found again in 2020 July from Japan, they looked at the unexplained women with unexplained miscarriages, and 20% of these women had neo-self antibody positive. So these are newer antibodies which we don't normally test for. And they have found that new kind of autoantibodies are positive in unexplained RPL in Japanese women in 20% of the unexplained recurrent miscarriage group. And these antibodies also lead to thrombosis. So I think we need to have a lot more research on what is the autoantibodies we are looking at. Perhaps our diagnostic modalities are still not very refined, and we will soon come up with so many more autoantibodies that we can test. Now, what is the treatment? If you diagnose somebody, you don't want a poor pregnancy outcome, what all can you give her? And here again, there is a long list, and often we end up doing a cocktail therapy of progesterone, HCG, heparin, low molecular weight aspirin in women with APLA syndrome, steroids, IVIG, intralipid. And I will take you through the evidence for each one of them. So, in autoimmunity, progesterone actually is beneficial. It not only sustains pregnancy endocrinologically, but also immunologically. And it is actually used as an anti inflammatory agent in women with severe rheumatoid arthritis to suppress their inflammation. So these women should definitely receive progesterone supplementation. HCG, besides triggering ovulation, downregulates maternal cellular immunity to promote implantation. And that is why there are studies on giving HCG intrauterine. But in these women who have autoantibody, it is important we give them some HCG during the luteal phase to promote implantation. Heparin and low molecular weight heparin have had the best success story in RPL with patients with APLA syndrome. And we must not forget that they help these patients not just by their anticoagulant action, but by their very powerful complement inhibitory action. And so, in most thrombogenic antibodies, it is important we give them heparin low molecular weight aspirin. As I said, the leaky gut needs to be fixed in autoimmune disorders, and the leaky gut requires a prescription of probiotics in a large dose. So, lactobacilli, more than 1 billion colony forming units, given pre pregnancy and continued during pregnancy, roughly a course of 3 to 6 months is required. And this will control the endometrial inflammation. IVIG, if there is one place you want to use it, it is in women with autoantibodies. And this has been very well shown by a randomized double blind trial done by Ole Christensen in 2019 in Denmark. And women that have APLA syndrome and they are not responding to aspirin, heparin, or women that have other autoimmune diseases are benefited when we give them IVIG in a dose of 0.4 grams per kilogram. However, the same group then looked at IVIG in unexplained RPL, where no autoantibody tests were positive, and there was no difference in the outcome in the IVIG or the placebo group in this study. So it is indicated in autoimmunity, but not in unexplained RPL. And the same is true for intralipid. Now, the baffling question is steroids. And we have always said that APLA syndrome, we don't need to give steroids. They do not improve the outcome. But in non-APLA cases of recurrent miscarriage with autoimmunity, short courses of steroids, which are administered preconceptionally and continue till 6 weeks of pregnancy or till a fetal heart is visible on ultrasound, has beneficial effects. I have personally used it also, and it is important that we remember that high dose of steroids can cause a cleft palate, and they should be stopped as soon as implantation is evidently complete. One good marker, if you want to see which of your patients will benefit with steroids, is to do a luteal phase endometrial biopsy. And if it shows a high natural killer cell population, it tells you that there is some endometrial autoimmune disorder. These are the patients where steroids will help. Don't forget vitamin D in any one of your patients. It is better to give them more than overcorrect than undercorrect, and it is better to correct the deficiency prior to pregnancy. And another trace element that is beneficial in autoimmunity is selenium. Selenium deficiency is associated with impaired B cell immunity. There are lots of studies on selenium prevents breast cancer in women, and it has an impact on inflammatory activity in thyroid specific autoimmune disease. So you give it as a tablet of 200 microgram per day for 3 to 6 months. And I personally also have experience of taking it. It smells rather bad, but it's supposed to be a protective trace element. I'll not dwell much on anti-TNF alpha because we are not doing this assay, but this is important in women who have like uncontrolled rheumatoid activity. They have high TNF alpha levels, and then you need to give them a cocktail of all these medicines: progesterone, HCG, low molecular weight aspirin, steroids, vitamin D3, and either IVIG or intralipids. And don't forget the autoimmune diet. So there are potential allergic grains like gluten. So it's better you consume non-wheat grains like oats, like bajra, jawar. And our country is very rich in all, or makai, all of these are freely available. Then avoid soy, egg whites, nuts like peanuts. Give high dose of probiotics, and there are other beneficial treatments like giving L-glutamine or N-acetylglucosamine. So these will help the gut heal and will prevent high levels of antibodies. Well, the new thing we have to talk about in nearly every disorder now is stem cell therapy. And there are very few studies, but there is a group in UK that is looking at stem cell therapy in RPL, and we are waiting to see what their results show. And lastly, linked to stem cell and increasing the colonies of endometrial mesenchymal stem cells is the drug sitagliptin, which is used in diabetes for glycemic control. So this write-up is from up-to-date January 2020, that we need to do more studies on sitagliptin as an agent that can help patients with RPL. So my take-home message has been, think autoimmunity when you have a patient of unexplained RPL, because it'll cause various placental disorders, placental apoptosis, prevent trophoblast invasion, and cause not only early pregnancy problems, but also late pregnancy problems. Thank you very much.
Thank you so much, Dr. Mala. She has explained very nicely. And as she explained, anti-phospholipid antibody syndrome is very important, as it constitutes around 22% of RPL cases, and TPO antibodies also. And main thing she highlighted the antibodies which should be tested, that ANA, anti-DSANA, anti-TGAB, anti-mitochondrial AB, anti-smooth muscle AB, anti-soluble liver AB, and anti-CCP, anti-SA, and CRP. This is very important. Otherwise, we are in dilemma which antibody to test. She has very much informative and explained very lucidly. Thank you so much, Mala. Over to Ame. Over to Pratik.
Yeah, I
May I
think
please?
Pratik, we can move on to the next speaker.
Yeah, we can do that.
Yeah, I request Dr. Archana Verma to please introduce Dr. Mandakini.
Madam, you'll need to unmute, please.
Special word about Professor Mandakini Pradhan. I am her favorite person and she is my favorite person. Okay. So the respect and love for each other is very mutual, as we have worked a lot during the Foxy year together, as well as we were co-conveners for the prenatal counseling and the prenatal checklist development under Dr. Alpesh Gandhi's presidential year. So always a pleasure listening to Professor Mandakini Pradhan. Over to Dr. Archana Verma for the formal introduction.
Thank you, Dr. Amaya. डेफिनेटली डॉक्टर प्रतीक एंड डॉक्टर अमय की जोड़ी बहुत सुपर हिट है और एमॉक्स को हाईएस्ट एंड हायर तक पहुंचाने में बहुत ही इम्पोर्टेंट योगदान. और डॉक्टर मंदाकिनी जी मैडम, आई एम वेरी happy to introduce you. She is one of the best, one of my best friend when she was contesting. She wrote to me, like in short, they give their introduction Pradhan M. तो I said कि डॉक्टर मंदाकिनी, आई थॉट कि मेरे को सीधे प्रधानमंत्री के यहाँ से मैसेज आया है, एंड यू आर नो लेस देन डॉक्टर प्रधान एम. And definitely it was a very good introduction of Dr. Mandakini Pradhan, and she was so much popular by this name only, and she is one of the most educated, I must say, the person with so many degrees, doing PhD and all. I don't know, I can't even think of studying and know that. And she's a look से बहुत simple लगती हैं, योगिनी ही कह दो इन्हें, another that person, and but she is doing marvelous work internationally also, highly recognized, and she does intrauterine transfusion within blink of her eye, and such a popular and famous person, Dr. Mandakini. Now she is from a professor and head of the Department of Maternal and Reproductive Health, SGPGI, Lucknow, and she's a chairperson of Genetics and Fetal Medicine Committee, and doing a lot for FOXY, and so many achievements, awards, paper, and publication, innumerable. And she has obviously she has done so many publications, more than 100 papers, I must say, must be online. And Williams textbook, she's quoted her publication, and she has been awarded by Bangladesh Ultrasound Society in 2019, and awarded Nari Shakti in 2020. When 2020 who gave you Nari Shakti? Prime Minister must have given him. Then Bharat Gaurav Samman again in 2020, and many more. And so we are Dr. Mandakini, please, now the mic is and the stage is yours. Let's hear to Madam Superstar Mandakini from Uttar Pradesh, Lucknow. Unmute, Madam.
Yeah, it's good afternoon, everybody. And that was an elaborative, extended type of an introduction. Thank you, Dr. Archana, to pull me into FOXY. In fact, I was not those types to go into FOXY, but then I enjoy every bit of it. That has given me a platform to at least disseminate knowledge so that we can move forward. Thank you, Emox, for giving me a chance again to talk on something which I always love. That is my love for genetics. And just a minute, I have to share my screen. So this is next. Next few minutes, I will be 30 minutes. I'll be speaking on genetics in modern medicine. At the outset, I thank EMOGS, but I thank Dr. Pratik Tambe, who nicely, Parikshit Tang, who nicely accepted that I should be talking first, so that I can go for the foundation day ceremony of my institute, where Chief Minister is coming, and all the professors and head of the department are requested to be present physically in the auditorium. So thank you so much. So next 20 minutes, I'll be talking on genetics in modern medicine. The moment we hear about genetics, we definitely have such type of a reaction, and many of us will have this type of a reaction. And then some of us will think it is something which need not be talked about. It is something which probably we should not know more about, and then try to escape. But what happens? Can we escape genetics at this era? Probably not. And we start thinking about it and start learning about it. This is the right time that we must start learning about genetics, because without genetics, probably our practice, both in obstetrics and gynecology, will be difficult. So I'll be covering this demonstrating few situations where our genetic knowledge is essential. Then some chromosomal abnormality. I'll be going on to microarray, then sequencing, or what is called as NGS or next generation sequencing. I'll be telling some cases, and I do not have any conflict of interest in this presentation. All the photographs that are posted over here, a proper consent has been obtained from the patient for using their photograph by me only, and hence I request nobody to copy these photographs. These are clinical photographs. So we see during antenatal period, say first trimester, second trimester, or even third trimester, we come across many malformation in the fetus, and or we read about a malformation, report of a malformation in the fetus, and then we are at lost. And sometimes we know what is it. Say for example, if there is some say absent nasal bone and doctor's reversal, then these days we know that it could be Down syndrome. But something like a protruding eye or something like say double bubble, we may wonder what to be done in the next, and might as well tell the couple also. And at birth, we sometimes see such type of a malformation or a baby being delivered like this, like both the eyes are together, or a patient coming with a photograph of the previous side having a cleft lip palate and some more malformation, maybe a clinical situation that we come across. So what are the clinical situation, common clinical situation where our genetic knowledge is essential is recurrent spontaneous abortion that Dr. Mala nicely talked about, the immunological factor, but then a subset of it, say 5 to 10% of it may have a genetic defect that includes chromosomal defect and single gene disorder defect. Then screening for Down syndrome, all of us are very fascinated about double marker, quadruple test and cell-free fetal DNA now. But then what to be done next? Bad obstetric history, previous history of stillbirth, neonatal death, fetal malformation, previous mental retardation. That's a huge set of population that we do see, and put all of these as cerebral palsy. It is not all who are cerebral palsy. Friends, specifically remember that if previous 2 children are affected with mental retardation, it cannot be cerebral palsy in both the babies. Then any previous malformation where we do not know the details of the malformation, and sometimes some maternal diseases. So coming on to this couple or this family pedigree where we are seeing 5 spontaneous abortion, and on examination what we got a report of 46XX, that means it is a carrier in the female, the abnormality in the female or in the wife, and there is T, which stands for translocation between chromosome 4 and 12. So what do we do? These patients, all of them should opt for a ovum donation? No, it's not that. So let's know about it. So what is our background knowledge of genetics is, we have got, every cell has got 46 chromosomes. There are 44 autosomes and 2 sex chromosomes. All of us know about it. But then I will be using this analogy of the book, that is words make sentences and sentences makes chapter, pages make a book, and books are kept in rack which can be put systematically in a library. And so for example, we have got 2 rack of anatomy books which may represent 2 chromosomes. So using this analogy, I'll be explaining what are the tests to be done. So alphabet makes words and lines and page and book rack. So similarly, we have got these the alphabets which represents ATGC or the adenine, guanine, cytosine, thymine, the base pair, and then 3 of them combine to form code for 1 amino acid, and that is called as a codon. And multiple codons makes a gene which codes for a protein, makes a protein, and these proteins or these genes are stuck together in to form a gene and a chromosome. Multiple genes makes a chromosome, and this chromosome what we look in a chromosomal analysis. So in a chromosomal analysis under a microscope, it looks something like this. Can we make out if the books in the library are arranged something like this? Can we make out anything out of it? If any book is missing or any book is duplicated, we cannot make out, and hence we need to arrange the books in an order of that order such that we can make out whether anatomy, physiology, biochemistry and all these book racks are systematically arranged or not. So arranging these chromosomes, what are seen under a microscope in a systematic manner, is known as a karyotype. So here I have arranged my library and numbered them as per the, which represents each chromosome and has been numbered. So now similarly under a microscope, the chromosomes looks like this, and after arranging it looks like this, and they are numbered as 1, 2, 3, 4, and if there is any deletion, duplication or translocation are looked into. And they are, what we need to know is this test is done on a blood which is collected on a heparinized vial, and from the lymphocytes which are nucleated, they are cultured, and the dividing cells are arrested at a phase of the cell cycle or metaphase of the cell cycle, so that it can be read under the microscope. So what we need to know about, we need not do this test ourselves. We need to know that the blood is to be sent in a heparinized vial, and it is the live cells. They can divide, and hence the tissue has to be live and to reach the lab in a proper time so that lab can do the test. Otherwise, if you go on sending product of conception of missed abortion where all the cells are dead, then there will be no dividing cell, and the lab will give a report that the karyotype is not possible or there is culture failure. So next, coming on to detection of abnormality. Here see, all racks are 2 in number. Suppose the rack number 21 has got 3 racks of books, so otherwise known as trisomy, and because it involves chromosome 21, so it is called trisomy 21, which commonly we call it as Down syndrome. So this is a numerical defect, and trisomy 21 we come across in spontaneous abortion, antenatal screening. We may see a previous child and the mother has come, and here I have reported a case of fertility in men in Down syndrome. So in an infertility clinic, husband is found to have Down syndrome, which is rare. So similarly, trisomy 18 and trisomy 13 can be seen in our clinical practice, which are so obvious that usually our ultrasound picks them up. So we concentrate only on trisomy 21 for screening, so that ultrasound may miss it and we have to diagnose them antenatally. Similar to trisomy 21, 18, 13, we can have a chromosome which is less in the sex chromosome. So one less is Turner syndrome 45XO. That we remember. We see them in as primary amenorrhea and short stature with multiple other findings. Similarly, if a suspicion of partial mole or a huge placenta, large placental thickness with a fetus which is growth retarded, there the chromosomal pattern, if each chromosome are 3 in number as seen over here, then the whole set of chromosome is excess, which is called as triploidy. So hence there are 69 chromosomes. This is a condition which is partial mode. So all these are chromosome number defect, but it can have a structure defect which can be translocation, deletion or duplication of a part of chromosome. A translocation, that means exchange of material between 2 chromosomes, and because there is no loss or gain of material, then it is called balanced chromosomal translocation. Whereas deletion and duplication, there is loss of material or gain of material, and hence it makes the person unbalanced as far as the genetic material is concerned, and there will have some amount of clinical manifestation. So here is chromosomal rearrangement. If you see this this thing, the chromosomes or book rack, then part of it is got translocated to this. Say for example, pathology books are shifted onto anatomy rack and anatomy books onto pathology rack, but there is no loss or gain of material in that whole of the library. So hence it is translocation between chromosome 2 and 10, and is written like T stands for translocation between 2 and 10. So how the gametes will be formed of such a person? A normal person will produce 2 sets of normal gamete. They are 23 in number. But if there is a translocation between 2 and 10, one will be a gamete which will have both the normal 2 and 10, whereas the other can have a balanced translocated carrier, and that is known as a balanced translocation. But it can be other way around also, like this thing. One is a normal 10, but this one is a translocated 2. So because of the translocation, this part of the books are duplicated in this gamete, and similarly this part of the book is duplicated in this gamete, and hence the gametes become unbalanced. So there will be monosomy, that means less amount of gamete, the genetic material in the gamete, or trisomy, or excess of gamete, genetic material, and these results in spontaneous abortion. So in a patient, in such a patient, we see why we see spontaneous abortion is because of this, that this unbalanced gamete results in spontaneous abortion. So in a couple who have got recurrent abortion, we see reciprocal translocation between 2 chromosomes or a Robertsonian translocation. That means that these 2 chromosomes, this chromosome 14 has got attached to chromosome 13. So because 13 and 14 are attached together, so the on counting there is one less chromosome, that is 45. There is a translocation between 13 and 14, but there is not, part of it has not gone. The whole of it has gone. And hence our counting is 45, but it is again a balanced translocation. So Robertsonian translocation are seen in acrocentric chromosome where there is no P arm or a short arm. Similarly, it can be 21-21 translocation. Why I am talking about it is there can be a 14-21 translocation, as I mentioned in this book rack example, and in them there can have a normal, like between 14 and 21, and a balanced carrier chromosomes can be formed, whereas in 14-21 balanced carrier, the gametes can be normal or balanced carrier, but it can be unbalanced gamete. So when there is a Robertsonian translocation between a different set of chromosome, a normal gamete is possible and a balanced carrier gamete is possible along with unbalanced gamete. But what happens if it is 21-21, or in other words with the same chromosome? That means 21 has gone and got attached to 21. So in a 21-21, all gametes will be unbalanced. So what will happen? If all gametes will be unbalanced, so the recurrence risk of spontaneous abortion will be 100%. In that case, what will happen? All fetuses will be, if it involves 21-21, then all fetuses will be trisomy 21. In such a couple, we need to have gamete donation. So our report and its understanding helps us in deciding in which patient we will have a donor ovum or donor gamete advice. So what happens in a balanced chromosomal translocation carrier in a couple who is a carrier of this is, if a female is a carrier, then 5 to 10% recurrence risk. If male is a carrier or husband is a carrier, then 3 to 5% recurrence risk. Outcome will be same as that of previous pregnancy outcome. If it resulted in recurrent abortion, if congenital malformation or mental retardation, the subsequent pregnancy outcome will be similar to that. And you can diagnose the unbalanced pregnancy by doing a CVS at 12 weeks or amniocentesis at 16 weeks. And if it is unbalanced, then advise a termination. If it is balanced, it needs only counseling. So what are the indication of doing a chromosomal test is recurrent abortion we saw, screen positive for trisomy 21, malformation, mental retardation, neonatal death, ambiguous genitalia, one of those major cause, then primary amenorrhea, premature ovarian failure, and male infertility. So chromosomal abnormality, we now know it can be number abnormality, it can be translocation structure abnormality. So one thing can be abnormality which is detected by doing a chromosomal analysis. But here is an abnormality not detected by doing a chromosomal abnormality, by a chromosomal test. So what test should we do? See, if there is large amount of anatomy book got shifted to pathology, then it can be detected by a chromosomal test. But if there are pages which are missing, for example, in this book, say 49 page, then after that it is 51. Or there is 50 and then 50. So either a deletion of 50 or duplication of 50 page cannot be detected if I go and look for anatomy books in that rack. If I look into this book, I cannot detect a page duplication or deletion abnormality. And hence, doing the test is called microarray. So here is an example of a case presented to us at 28 weeks, corpus callosal agenesis, retrognathia, micrograthia. We did a chodocentesis, we did karyotype. At that 2016, we were doing only karyotype, it was normal. Continued the pregnancy, delivered a term, female baby, MRI showed agenesis of corpus callosum. This was the baby, this was the MRI report, and afterward we did a karyotype which showed a deletion of some part of the gene. So subsequent pregnancy, of course, was managed successfully. So what did we learn from it is, if there is a malformation, then microarray is the test to be done if you have done a chromosomal analysis or karyotype which is normal. Microarray is a DNA test. It can be done on dead tissue. Blood can be collected in a EDTA vial and sent to the lab for doing this test. There are committee opinion which says that fetal malformation, if your karyotype is normal, you go ahead and do a chromosomal microarray test. It looks into, as I explained, into pages. Similarly, it looks into the chromosome and smaller deletion or duplication are seen. So if there is abnormal ultrasound and normal karyotype, then 6% fetuses can be abnormal. So to pick them, we should not stop at the normal karyotype. We should go ahead and do a microarray test. In our series, we also found that 3.76% had abnormal microarray without any fetal malformation. That was very alarming for us. Hence, subsequently, we offer patients to have a microarray if they are opting for invasive testing for any other reason. So fetal malformation microarray, stillbirth microarray, invasive test done for any other indication, you ask the patient to have a microarray with some additional cost. Previous baby with mental retardation with normal karyotype, however, it has to have a pre-test and post-test counseling, which are given in various forums. So now coming on to, if our page number is same, are exactly absolutely normal, then what can I do? Still the baby is abnormal. What can I do? Say I start reading every word of those books and what is called as a sequencing. Say for example, the sentence written in this book is every village should have a toilet, and instead of toilet is replaced, I is missing, and so it has become toilet. So every village should have a toilet, or it is replaced by omelette. Every village should have a omelette. So every one of that village should are we. So what I mean by that is the meaning of the sentence exactly changes by changing one or two letter of the sentence of a word. So similarly, in the gene, as I explained that letters forms a codon and codon forms a gene, protein and protein forms the gene. So then if there is a change, then that is to be picked up, which has an abnormality, and the picking up is called as a sequencing. And change in base pair, ATGC, replaced, deleted, duplicated, leads to change in amino acid and hence leads to change in protein. And if we read whole of the books of that library, then what is called as a whole genome sequencing. If we read the useful books in that library, then that will be called as whole exome sequencing. If we think that it is only obstetrics we are interested, we go on reading only obstetrics book, or we look into those genes which are essential for the clinical manifestation, then it is called as clinical exome sequencing. If we want to specifically look into one chapter of the obstetrics book, for example, normal labor in the Williams textbook, then that is in analogy is called as mutation analysis for single gene disorder. If I can able to put across this thinking to you, probably my talk is sufficiently explainable. So what is clinical exome sequencing is, in that whole library, I do not know which book to open and start reading. I'll be really confused in that library. So if you tell me, after clinical evaluation, there is a computer assisted gene selection. For example, if I put hearing abnormality, the computer will give me 30 or 40 genes. And that set of genes are sequenced. It reduces the cost, it reduces the time. For example, this patient in this family, this was the child, and 2 children were affected with deafness. There was no malformation. So we went ahead and did the clinical exome sequencing of this child, saying the lab that the children are affected with deafness. They looked into the genes responsible for deafness, found out a mutation, and that same mutation were looked into both the parents, and parents were found to be carrier of that gene. So this can be helpful in doing a clinical exome sequencing. Clinical information is given to the lab. So here is a case of little deviation from that. 15 weeks gestation came to us with history of one early neonatal death, one infant death, some neurodevelopmental delay. This was the family, consanguineous family, and supervised, well, uncomplicated pregnancy, 39 weeks, 2.5 kg, baby, no malformation. Baby died on day 3 of life in NICU and detected to have meconium aspiration. This is a very common clinical situation that we come across. Second pregnancy, supervised normal delivery at a medical college. Developmental delay noticed at 6 months, seizure at 1 year, karyotype normal, MRI, white matter, neurodegenerative disorder. Enzyme assay were done, they were normal, baby died at 22 months before any further investigation. So what we have is, in the third pregnancy, we have a information that one of the baby was investigated, karyotype normal, MRI showed some neurodegenerative disease. So what did we do? We went ahead and did, because they presented to us at 15 weeks, we did the next generation sequencing of both the parents. And what did we found? This both of them, we found a mutation in one of the gene of WFS1. Friends, please do not think that Dr. Mandakini remembers all this. Again, she goes back and starts reading what is this WFS1, which stands for, and start reading about those disease. And we found out a disease which was there in that this couple, and the husband was tested. Husband was found to be a carrier of that, and then we went ahead and did the amniocentesis. The fetus was found to be normal, continued the pregnancy, the child is normal. So this clinical exome sequencing is helpful if your karyotype, microarray are normal. Test the affected child first. If not possible, then test couple. Test one couple first, then same defect can be tested on the other couple. This will prevent you in spending a lot of money. Other investigation will guide you. Say, for example, MRI guided us to tell the lab that there is neurodegenerative disorder. better to see the couple in pre-conception period. So coming on to single gene disorder, can I have 5 minutes more? So I move on to single gene disorder. We know, suppose for example, I need to know about cardiac output in pregnancy. So what do? I go to obstetrics William textbook chapter 4 page number this. So this is what is depicted over here. So here we know the clinical disease is identified, defective protein is known, and gene is known. Same gene is tested by various methods to find out the abnormality. For example, beta thalassemia. Say beta thalassemia, we know that the disease is beta thalassemia. The defect is beta globin gene, which is present on chromosome 11. So we look for mutation in the beta globin gene to prove that it is beta thalassemia. If the common mutation methodology doesn't find out any mutation, then we go ahead and do the sequencing of beta globin gene. So here is the HPLC shows that it is a carrier for beta thalassemia, and similarly we move ahead and do the test. Say for example, clinical examination of this woman and her child shows that it is neurofibromatosis. So hence we can order the lab to look for mutation in neurofibromatosis gene. And similarly here, encephalocele and polydactyly points towards Meckel-Gruber syndrome. We ask the lab to look for Meckel-Gruber syndrome. This is one of the common muscle dystrophy that is seen or called as DMD, which affects male, and mutation analysis of DMD gene. 2 ml blood can be sent to the lab for the test. Recurrence risk is 25% or 50% of the male. Prenatal diagnosis is possible by doing a CBS at 12 weeks. So diagnosis after suspicion, sometimes you have to dig out what was the previous child affected with. If previous respiratory distress, start thinking about spinal muscular atrophy and cystic fibrosis, for which mutation can be done very easily. Previous ambiguous genitalia, think about congenital adrenal hyperplasia. Previous short limbs, definitely skeletal dysplasias. Previous baby requiring blood transfusion, specifically after 5 to 6 months of age, is thalassemia or sometimes sickle cell disease, rarely sickle cell disease. And sometimes you see in the fetal life such a big, huge balls like thing in the heart or a tumor in the heart. Then you suspect tuberous sclerosis, you do a genetic analysis, you find tuberous sclerosis. One slide on infertility. After doing a clinical examination, if you are thinking premature ovarian failure, do a chromosomal analysis. Of course, examination of the male partner. And for chromosome analysis, if it is azoospermia, oligospermia, then Y microdeletion can be tested. Bilateral absence of vas difference, CFTR mutation. Cancer genetics, I did not go into detail. We probably have to have some time about. So what I talked about is karyotype or chromosome analysis can be done on live cell. Please remember this. FISH is to look for that specific chromosome. So we ordered the lab for FISH for chromosome 21, chromosome 18 or 13. Microarray can be done on any tissue when chromosomes are normal. Clinical exome, affected mental retardation, skeletal dysplasia, skin abnormality. Specific known disease, mutation for that disease can be done. So for this talk, I acknowledge all my patients because of whom I am literate and I have learned whatever I have learned in my life. All my faculties, resident, molecular lab that is supported, and Foxy, my dear friends who have encouraged me to improve upon my slides and be better next time. If I have done something less explainable, probably you can point it out. I will try to make it more lucid. Thank you so much, and thank you, Dr. Pratik.
Thank you, Dr. Mandakini. It was as good as expected, and that test about you karyotyping and microarray, that difference and when to do and when not to do, I think Dr. Pratik will, and Dr. Amay Purandre, he is a very smart person. He knows everything. he will better tell. And I think now, Pratik, अब कोई और question हो तो I have no मेरे तो बियॉन्ड रहता है ये सब चीजें जेनेटिक्स.
Thank you, Dr. Mandakini, for that excellent talk. You really simplified the entire tough subject of genetics and told us what is the practical utility of this subject. I think it has immense clinical application, especially in OBGYN, as you have shown, right from fetal studies to infertility and also cancer. So I think people like you who are dedicated to this field will definitely help the patients, especially those in whom routine clinical investigations and treatment would not help. Then genetic counseling and genetic therapy would definitely be beneficial in those patients. So, Pratik, can we move on to the next speaker?
Hello. She has elaborated very nicely, and basically she is from our side and she has done DM. So I think it's very useful, right? Because she is applying her knowledge in that field. So that's why her lectures are really very nice. Always listenable. Thank you so much, ma'am.
Yes, and Dr. Mandakini, I liked your slide. और आपसे बाद में ले लेंगे. पब्लिक अवेयरनेस में बहुत काम आने वाली है, क्योंकि वो पेज और वो लाइब्रेरी बना दी थी ना आपने, वो वाला, दैट आई लाइक्ड वेरी मच.
Thank you.
Thank you, Dr. Mandakini madam, for joining us in spite of your busy schedule, and we are thankful to you for sharing your knowledge, and we won't hold you any longer. I see that there are no audience questions so far. If there are any, then we will have you back again. Thank you so much.
Okay, thank you.
Can move on to the next speaker. Can I have the slide, please? It gives me great pleasure to introduce a close friend, a colleague, a well-wisher, a partner, a co-Twitter enthusiast, and someone whose company is really enjoyable to all of us. None other than Dr. Parikshit Tang. Dr. Parikshit is a consultant at the Ashwini Maternity and Surgical Hospital and Center for Endoscopy and Assisted Reproduction at Ghatkopar, Mumbai. It is one of the well-known hospitals in Ghatkopar with over 3 decades of a legacy in Ghatkopar. And his family has carried that legacy, and Parikshit, that is something that you need to be very proud about. He's also a consultant at Jupiter Hospital, Thane. Parikshit has extremely good organizational skills, and he's fulfilling them with great responsibility as the joint treasurer of Foxy. He has been a chairperson of the Safe Motherhood Committee of Foxy between 2014 and 2017, and a managing committee member of Mumbai OBGYN Society for so many years. He has had a stellar academic career and has been awarded the K. Bhaskar Rao Gold Medal for first place at DNB, the Kamini Rao Yuva Foxy Orator of 2011-12. He has over 100 peer-reviewed publications in index journals, CME publications, and textbooks, and has co-authored 4 books in OBGYN, and is also on the editorial board of 4 index journals. So we have a person with great wit, great wisdom, and dominant whiskers this afternoon, talking to us on a very important topic of OBGYN. Over to you, Parikshit.
Thank you, Amay. That's a very kind introduction on your part, and indeed, the sense of company is mutual. My best wishes to you for your upcoming post, or should I say the process of becoming the Vice President of AMOGS. I wish you all the best, and I'm sure that all the constituents of AMOGS will do so too, and they'll benefit from your leadership skills immensely. My thanks right at the beginning to Pratik for the invitation to be here today, to Dr. Verma, the Secretary and President, Dr. Nayak and Dr. Palshetkar of AMOGS, and the ICOG office bearers, Dr. Biniwale, Dr. Meg, for making me a part of this wonderful CM. So what I'm going to talk about is preeclampsia remote from term, the hazards which go with it, and what can we do to solve these problems that we might come across. So we are quite familiar that the incidence of preeclampsia and eclampsia has remained more or less constant, and it is still one of the important causes of maternal mortality and morbidity. Typically, if we look at how the incidence goes, and this was probably the first scientific approach towards studying preeclampsia by Leon Chesley, and in the late 70s, what he put forth was that about 10% of primigravidae are affected by hypertension, 2% have severe affectations, and about 2% will have the severe disease before 34 weeks of pregnancy. If we look at maternal outcome, it has been well documented that there are differences in the developed nations and the developing nations of the world. And it's not only to do with the incidence of eclampsia, but it's also to do with the outcomes as far as the mother is concerned. So this data is a little older, about 15 years older, and then we've got this beautiful, very comprehensive global survey, which was published in the Lancet in 2014. Hypertension and diseases related to hypertension in pregnancy still contribute to about 15% of maternal deaths. So it is something which is still quite sizable even in 2020. And obviously, the question which one would ask is, why are women still dying? Why are they dying even now from eclampsia? And this was a review of the status, the literature for FIGO that Dr. PK Shah and I did. The factors which came across from the literature on maternal mortality and the events surrounding maternal mortality in eclampsia, twofold. One is a lack of awareness, availability, or correct practice of magnesium sulfate usage. And the second issue are related to infrastructure, that is, the lack of an HDU concept in developing countries, and the lack or not following the set protocols and guidelines as far as severe preeclampsia management is concerned. Now, this may look very familiar, this may look very obvious, but still about 50,000 mothers are dying from hypertension and eclampsia every year annually across the globe. The same is true for perinatal outcomes. There are differences in developed versus the developing countries, and perinatal mortality and morbidity is significant in hypertensive disorders. Now, one thing that we have to understand is that perinatal outcomes are related to the placental insufficiency and the complications of premature delivery. It's not dictated entirely by the level of maternal blood pressure. That's not the single most important factor. It's what this maternal blood pressure does to the maternal systems and the fetal vasculature that determines what is the fate of the perinatal outcome. So, early delivery is associated with poor perinatal outcome. It's compounded by prematurity. And if you decide to wait, the maternal outcome gets compromised. And that's what we are worried about when we think about expectant management. So the hazards of early delivery are the poor perinatal outcome because of the higher incidence of respiratory distress, necrotizing enterocolitis, and sepsis, and delivering somebody through an unripe cervix or hasty decision making is going to contribute to maternal outcomes going negatively. The hazards of waiting: higher risk of maternal complications, eclampsia, HELLP syndrome, abruptio. All these dreaded events start becoming more common the longer we wait after the diagnosis of severe preeclampsia has been established. And it would also compromise fetal condition due to a worsening of the maternal state. So here we have the two sides of the balance which we need to equalize and therefore come to some sort of decision making process in severe preeclampsia. If the gestational age is beyond 32 weeks, or if one is in a center where neonatal care facilities are not so great, one might stretch this to 34 weeks. And at this point, especially in urban settings with good NICU facilities available, in the presence of severe preeclampsia, the decision to deliver becomes quite obvious. The same is true for pre-viable gestations. Suppose you have a very early onset, 22 weeks, 24 weeks, even with a desired pregnancy, but with severe or fulminating preeclampsia, imminent eclampsia, the decision making becomes very obvious. You know that you're not going to be able to pull this delivery through by waiting for another 4 weeks or so. You know that it's an outcome of days, and therefore it becomes quite important to make that hard call and deliver this woman any which ways. So if it's at the extremes beyond 34, before 26, the call is very simple. It's quite straightforward to take. But the gray zone is between the 26 to 32 weeks. What should we do? Should we attempt expectant management of this woman who has severe preeclampsia, or should we go ahead and deliver in the best interest of avoiding any such outcomes which may be related to waiting? So if we decide to look at how to do an expectant management, we need good maternal assessment. And that starts from a simple clinical event, close repeated monitoring of the blood pressure, look at proteinuria. Often it is overestimated by protein sticks. So go for the traditional urine analysis type of an assay. Now, how often to do it and whether the fluctuations in the proteinuria really affect perinatal outcome? No, it doesn't. Once you've got 2 plus or more of proteinuria, then whether it is 4 plus on 15th of December and then becomes 3 plus, so does that mean she's improving? No, it doesn't. The fact that there is significant proteinuria is now enough to establish that she has severe preeclampsia. So there's really not much meaning in repeating proteinuria every day or twice a day, which was quite a common thing which was practiced when we were students, and we used to take rounds morning, evening, and proteinuria was measured repeatedly. Uric acid, in fact, is a much better predictor of perinatal outcomes than either proteinuria or blood pressure. And this is something that we should look at. Watch for HELP syndrome and the standard liver and renal function and a good CBC with a platelet smear to look at thrombocytopenia is what we need to pick up this complication early. We often do tests related to coagulopathy, but in severe preeclampsia even, DIC is a rare complication unless there is another event. So when would DIC occur? If there is another event which affects coagulation, like an abruptio placentae or a postpartum hemorrhage, antepartum hemorrhage, yes, then I expect that there is a risk of DIC. But otherwise, most of your coagulation profile is almost always going to be normal, even with severe preeclampsia. Today, the test of choice is a color Doppler, and its value is very well established in terms of predicting perinatal outcome. As long as there is end diastolic flow in the umbilical artery, prolongation of pregnancy is usually possible to allow maturity to occur, to allow the effect of corticosteroids to take place before we go ahead and deliver this woman. Usually the fetus, which has some end diastolic flow, will be able to tolerate this prolongation of the pregnancy. Of course, I don't mean to say that looking at other vessels is not valuable. Of course, it is valuable. Look at the middle cerebral artery blood flow. The earliest sign that there is some kind of fetal compromise, there is some significant fetal growth restriction happening, is a change in the cerebroplacental ratio. If it starts falling towards 1 or goes below it, that's when you know that there is some vasodilatation which is in the picture. But you're going to probably take a call in this remote from gestation setting based on the umbilical artery rather than the other vessels. Some would go even a step further and say that even if there is absent end diastolic flow in the umbilical artery, one might still consider prolonging the pregnancy if there is forward flow in the ductus, etc. But then you're looking down the barrel of a very deadly shotgun because metabolic acidosis is not far away for the fetus. You will use fetal ultrasound to look at growth, but here it's important to look at serial measurements rather than just one reading, and reduced Leica volume will also help in the decision making. Cardiotocography may be a simple and a standard test which almost every unit will have, but remember that it has very little positive predictive value. You're not likely to make decisions based on a single CTG. Of course, if you see that there is a loss of accelerations which was previously there is a deterioration of the variability, it would imply that the fetus is getting affected. If there are decelerations, you must consider them sinister at any time. But remote from term cardiotocography is not the test that I would recommend for making decisions as far as the perinatal outcome or taking the call to deliver this woman is concerned. Now, how do we monitor? Now we've got severe disease, we are remote from term, we want to wait for some time. How do we monitor this woman? I would strongly recommend that severe preeclamptics should be hospital admitted. They should be in your supervision so that you're more conversant with the day-to-day events. It's much easier to test these women. And if something does go wrong, you're in the right place to take action and prevent the catastrophic outcomes that we are familiar with. So admit these women. Proteinuria should be quantified. Do the blood work, uric acid, platelet counts, and the liver function on a twice weekly basis. You may do cardiotocography as you come towards the 34-week mark. Otherwise, we have to rely on umbilical artery Doppler and estimation of Leica volumes. The umbilical Doppler, how often should we do it? Well, if it's completely normal in severe preeclampsia, I would hold it off for another week. If there are some changes which have come up, I might repeat it after 4 to 5 days. We are all familiar with this triad or the levels of prevention when it comes to diseases. The primary prevention is the prevention of the disease altogether. And of course, we just don't have that magic bullet as far as preeclampsia is concerned. But when we want to limit damage, then we have to look at agents such as antihypertensives and anticonvulsants. And these become very useful when we are talking about managing severe preeclampsia remote from term, because they will be able to buy you some days, some more time to get to your goal of fetal maturity. So the role of antihypertensives in preeclampsia has to be well understood. It is to control the hypertension and prevent cerebrovascular accidents. It allows you to buy some time to prolong the pregnancy for fetal lung maturity by the steroids and allow you to transfer this woman to an appropriate tertiary care center where facilities for better neonatal care, or for that matter even better maternal care, are available. Let's not forget that antihypertensives will not change the pathophysiology of preeclampsia. They will not make a severe preeclampsia into a mild preeclampsia. The vascular damage which is happening at the level of the endothelium will continue even after the blood pressure gets controlled. So do not be under any false impressions that the control of the blood pressure is a control of preeclampsia. That thought should be banished forever. Now, when should you start the antihypertensives? With a severe preeclampsia, 160, 100 or more, the decision is quite clear. But if you look at what the summary of recommendations has been, I've just looked at what has happened over the last decade, and it seems like there is a trend towards a much tighter control of hypertension than what we were looking at even just as far back as 10 years. So the 160, 110 levels, which were typically talked about for starting antihypertensives, seem to have relaxed a little bit, or should I say that the criteria have tightened and one would probably start antihypertensives a little sooner. The hypertension guidelines from Canada 2018 even recommend starting antihypertensives at 140/90. The truth probably lies somewhere in between, and what we talked about in the Foxy GCPR 150/100 seems to be a rational choice of when antihypertensives should be started. What is their value? It halves the risk of developing severe hypertension if you start it when the woman has mild rise in the blood pressure. But of course, there is no difference in the onset of proteinuria, severe preeclampsia, fetal death, or preterm delivery, or the neonatal outcomes. What is the choice of antihypertensives? I think now quite well established that if you're looking at days or even a week of therapy, then you want oral agents like labetalol. If you're looking at acute situations, you want fast acting agents like nifedipine, but never sublingually, of course, always orally. Labetalol also is very useful, and in ICU settings, one might consider using intravenous hydralazine for hypertensive emergencies. What should you not use? Avoid diuretics, ACE inhibitors, and atenolol as far as you can avoid it. Atenolol is otherwise a wonderful drug, but being primarily a beta blocker, it may affect fetal growth. So, if possible, avoid it. What about magnesium sulfate and preventing eclampsia altogether? Before the first instance, this was the MAGPIE trial, now nearly 20-year-old. The inclusion criteria were uncertainty about magnesium use. And what did we find? We found a significant reduction in eclamptic fits, but the number needed to treat was quite large for mild preeclampsia. Again, no difference in the two arms as far as maternal morbidity and neonatal outcomes is concerned. And what about seizure prophylaxis? That means the first convulsion has occurred, and of course, we can always hark back to the collaborative eclampsia trial way back in 95, probably one of the benchmarks as far as good clinical trials in obstetrics is concerned. Two arms, magnesium versus diazepam, and the other one was magnesium versus phenytoin. Very clear outcomes. Magnesium reduces maternal and perinatal morbidity and mortality. Let's not forget that here, when we are talking remote from term, magnesium is going to give you another big plus, and that is neuroprotection as far as the fetus is concerned. And there are encouraging results from the data that has been coming in, and there is a positive effect as far as reducing the number of cerebral palsies and neonatal deaths. Earlier you use it in the gestational period, greater is the effect of neuroprotection with magnesium sulfate, and most guidelines will recommend using magnesium sulfate not only as seizure prophylaxis but also in preterm gestations. Here, of course, it will play a dual role, and definitely use it before 34. Some say after 32 it's controversial, but I think there's no harm. Do use it before 34 weeks of gestation for every delivery. What can you do today about reducing morbidity and mortality from eclampsia care point of view in your unit? Here are a few practical tips that I would like all of you to take home. Make an eclampsia kit or an eclampsia box. The details of it are available on the Foxy website. Do eclampsia drills, because this is now a relatively rare event in a nursing home. Make your staff familiar with what is to be done, how to open the vials, how to fill them, how much to fill them. Make sure that there is enough magnesium sulfate. At any given point in time, one obstetric unit should have at least 50 vials of magnesium sulfate. It's very cheap. Even if you have to throw it away after the expiry date, believe me, it's not a big loss. And keep a drug and dosage chart pasted on the wall of your labor ward so that the people who are there, usually we aren't going to be there when an eclampsia occurs. It's not the consultant who's going to see the patient first. It's going to be the junior doctors, the RMOs, or maybe even the nurse. If a woman has been brought in with convulsions and you don't want them fumbling at that time, a drug and dose chart will boost their confidence immensely in giving this very, very useful drug confidently. So, when should you stop with the expectant management if there are features which indicate the need for an expeditious delivery, uncontrolled severe hypertension, even with two antihypertensive agents, or if there are end organ damages like eclampsia, pulmonary edema, oliguria, there are features of imminent eclampsia, HELP syndrome, or if the fetal condition deteriorates, there's a deterioration of the color Doppler or the biophysical profile, severe oligohydramnios, then all these are indications to stop the expectant management, give it up, and plan delivery. Delivery, as we know, is the ultimate cure. The timing of delivery affects both the mother and the baby. You don't want a rush delivery in an unstable patient because it probably adds to her risk rather than reducing it. But at the same time, too much of delay in a sick patient can be treacherous. The route of delivery, we have to look at where we are with the process. If it's somebody who has already gone into labor, is progressing beautifully, fine, you can afford to wait for 2 to 4 hours and let the vaginal birth occur. But if it's a completely unripe cervix, especially in a primigravida, the chances of getting this baby through safe and sound are probably less than 1 in 5. So a cesarean delivery would be preferable in these circumstances, and this should probably be done safest by an epidural. If an epidural is not available, then a spinal block rather than committing to a general anesthesia. Let's not forget to care for the mother after she has delivered, because 40% of maternal deaths are going to be postpartum, and post delivery, the problems which could occur are relative oliguria and the dip in the platelet counts, especially where there has been a HELP syndrome. You have to be vigilant. Continued close monitoring is required in a suitable environment. And then, of course, you can go on and taper the antihypertensives gradually. So, as they say, there is nothing so useless as a general maxim. And of course, there's nothing like one size fits all in a disease that is as complex as severe preeclampsia. You have to tailor make, you have to judge where you are with the disease process, where you are with the gestational period, what sort of infrastructure and facilities that you have, and they then make the call about delivery versus expectant management. Thank you so much for the kind attention.
Thank you, Parikshit. It was indeed a brilliant presentation, as usual. And so a subject like preeclampsia is really tricky because the management poses a lot of challenges at various occasions, and especially severe preeclampsia and terminating the pregnancy takes a lot of efforts, and it definitely takes a toll on the obstetrician as well, because the just by merely delivering the baby does not solve the problem. It, as you very rightly pointed out, it does continue in the postpartum phase also, and we have to be extremely cautious even in the postpartum phase. As you rightly said about the renal failure, the acute renal failure is so common in the postpartum phase rather than even the during the antenatal phase. So thank you very much. It was indeed a very, very comprehensive presentation. Pratik, do we have questions for any of the speakers?
There are no questions for any
Hello.
of the speakers, only overwhelming amount of compliments for everybody. So thank you so much to all the wonderful speakers. I would invite the chairpersons to give their closing remarks.
That's because you've chosen speakers who are brilliant. Mandakini Pradhan, who's one of the best we can have as far as genetics is concerned, and Mala is equal to RPL. So whatever Mala says is the gospel truth as far as management of RPL is concerned. And for me personally, whenever we face challenges and whenever we faced any issues with RPL, just a phone call to Mala and she's there with a solution.
It was really wonderful webinar. This is, and thanks to all, Dr. Parikshit. It was really excellent talk, and thank you organizers, especially Dr. Pratik and Dr. Ameya. Ameya is really working hard in coordinating all the webinars, and he is now, we wish him every success for his next tenure as Vice President AMOX. I think he should get success. He is very
Absolutely.
active in
Absolutely.
AMOX, and he is working not only for 2-3 years, but I think many years, more than 20 years he is doing. So
I
Ameya,
totally agree, Dr. Pardeshi, and especially as far as Pratik and Parikshit and Ame are concerned, I always take the credit that they were part of my young talent promotion committee, and they both of them have made us really proud with their achievement.
thank
I'm
you,
sure
Parag.
Ameya will do what we all want him to achieve.
Thank you, Parag and Dr. P.A.C. Verma. Dr. P.A.C. Verma.
I think, Archana ma'am, maybe you can, the gentleman have,
Dr. Rajendra Singh, Dr.
I forgot-
Rajendra Pardeshi sir.
I forgot Archana, so I thought, अरे क्या नाम है तो P.A.C. Verma. I think
So
this is
I can say Dr. Pratik that अगर मतलब होता है ना कयामत से कयामत तक अगर कोई वेबिनार हिट करा सकता है तो वो प्रतीक और अमय की जोड़ी ही है, और डॉक्टर नंदिता की गाइडेंस में डॉक्टर प्रतीक, डॉक्टर माला, डॉक्टर पराग, डॉक्टर राजेंद्र, क्या स्टेलर स्टडेड जबरदस्त वेबिनार, जबरदस्त टॉपिक, जबरदस्त एकेडमिक्स, एंड थैंक यू वेरी मच फॉर कॉलिंग मी। पीएसी वर्मा नाम अच्छा लगा मुझे।
You'll be glad to know that we have 520 viewers today, in spite of
great.
it being a Monday afternoon event.
great.
सुपर हिट मैंने पहले ही बोल दिया ना, देखो मेरी लेजर भी चलती है थोड़ी थोड़ी सी।
It's due to
And
Pratik
Dr.
and
I think it was very well organized.
Thank you.
And I'm
Any
really
closing
glad-
remarks?
I'm really glad that you gave me the latitude to select a topic which I really love.
It always helps to give
Dr.
the
Pra-
speakers the
Dr.
time
Par-
and the topic, both of which should be totally liberal.
But Dr. Parikshit, we saw you, oh my God, the last webinar में panel, अभी तक लोग पूछ रहे हैं भाई क्या, it was wonderful, wonderful. I
The
think
PPH one, yeah, that was very good.
Pratik means panel Pratik.
हाँ panel.
uh, if I may conclude,
Yes, Ameya.
I thank,
Yes, sir.
I
Ji,
thank
sir.
the President AMOX, Dr. Nandita Palshetkar, all the office bearers for their constant support, encouragement in our endeavor. Of course, Pratik's single-handed zeal, passion, commitment to furthering academics and knowledge, and as well as fellowship for AMOX through these webinar series. Thank you, Pratik, for the excellent coordination and the excellent and meticulous job that you are doing. Of course, all the senior co-chairpersons today for their valuable inputs. And what can I say? If we have 3 Oscar awardees as the speakers this afternoon, any movie is going to be a hit. So you don't require Pratik or Ameya as the spot boys or the clap boys when you have such big Hollywood and Bollywood stars. So thank you everybody. Special mention to Subbu and his team, Science Integra, for the great job of science generation, and Bharat Serum for being our educational partners for this and many more such endeavors. Over to you, Pratik.
I just need to mention in closing the ICOG chairperson, Dr. Mandakini Meg, and the secretary, Dr. Parag Beniwale, for granting us the ICOG credit points. And we hope to see all of you very soon in another event. Thank you so much for joining us today afternoon.
Thank
It's
you.
always a pleasure
Thank you,
to be
Pratik.
with all.
Yes.